to Gadjah Mada International Conference on Tropical Medicine 2022, Day 1. As I mentioned before, we are going to attend the plenary session under the topic of global challenges in emerging infectious diseases. This plenary session will be moderated by Mr. Yodi Mahendradhata, PhD from Universitas Gadjah Mada. And here it is his profile. Mr. Yodi Mahendradhata is currently the Dean of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. He is a medical doctor by training and he obtained a master's degree in international health from the Institute of Tropical Medicine, Charité Medical Faculty, Humboldt University, Berlin, Germany. Mr. Yodi completed his doctoral degree in medical science at the Institute of Tropical Medicine, Antwerp, Belgium, and Ghent University, Belgium. He is currently leading the Southeast Asia Regional Training Center for Health Research, supported by WHO TDR. He has led developments of national strategy of implementation research, national strategy for tuberculosis control, and country proposals to the Global Fund to fight AIDS, tuberculosis, and malaria. His research interests are in the fields of global health, implementation science, disease control, health policy, and health program management. He has authored and co-authored numerous peer-reviewed articles published in reputable international journals. He has been awarded the Scopus Young Scientist Award by the United Nations University, Elsevier, and Alexander von Humboldt Foundation. Well, ladies and gentlemen, please welcome our moderator, Mr. Yodi Mahendradhata. Please, the time is yours.
Thank you. Hello, everyone. Welcome to the plenary session of this Day 1, Global Challenges in Emerging Infectious Diseases. Last September, Dr. Tedros, WHO DG, remarked that the end of the COVID pandemic is in sight. So it's a much awaited statement as the world gets increasingly weary and fatigued of a pandemic which has been dragging for more than 2 years now. Unfortunately, however, even when the COVID pandemic ends, it won't be the last pandemic. We are living in the era of pandemics, so the next pandemic is just a matter of when, and because it's very difficult to prevent it. So here the key is preparedness, pandemic preparedness, and another key is learning from the current COVID-19 pandemic. And that is what this session is all about. We have 2 international experts who will guide us through these challenges. We will invite them one by one, and each of them will present for around 20 minutes their views, their insights on these issues. And afterward, we will have a 20-minute Q&A together with them. So I would like to first invite our first panelist. Here we have with us Dr. Nirmal Kandel. He's a good colleague of mine. Dr. Kandel is a medical doctor with an executive master in business administration, in public health, and also a master in anthropology. He has more than 20 years of experience in health and development on national and international level. And he has worked in WHO's Health Emergency Program since 2015 at WHO HQ Geneva as the head of evidence and analytics for Health Security Unit. He was a technical lead and focal point for the National Action Plan for Health Security and the WHO benchmark for IHR capacities. He was also a technical lead in developing the JEE tools, processes, technical guidance, and training models. So let me just check, Dr. Kandel, can you hear us audibly?
Yes.
Yeah. So welcome, Dr. Kandel, to the session. You would like to start sharing your slides?
Yes, I'll do that.
Okay. Okay, just have to switch to, okay, very good. So the next 30 minutes is yours.
Thank you, Pak Yodi. Selamat sore Bapak,
Selamat
Ibu,
sore,
kita
Pak Kandel.
semua. Saya tidak bisa presentasi di bahasa Indonesia. Mohon maaf. But I will make presentation in English, and it's very delightful to be back with the Indonesian team. I still remember my 5 years time in Indonesia since 2010 to 2015. So thanks for the invite, and I'll walk through some lessons that we have learned from pandemic preparedness and recovery. So, as you know, there's an increasing number and impact of health emergencies with emerging threats, emerging infectious disease, as well as others like non-biological hazards, earthquakes, tsunamis, conflict, and these things. So, but risk is increasing not only because of those things, but risk is also increasing due to environmental degradation, urbanization, and international travel and trade. And there are a lot of social conflict, political conflict, and natural disaster also. And we have witnessed more humanitarian crisis needs, approximately 274 million people in need across 63 countries. And recently, with the pandemic, we have noticed that huge socio-economic impact, and it's accounted almost 12 trillion in international revenue losses due to COVID-19. What I'm trying to say with this slide is that these are the events that you can see in the past, and we have learned so many lessons in the past also, but this even COVID pandemic or any other events that ongoing right now are not the last one. And there will be other also. As you know, there's around 70% of the emerging infectious disease comes from the genetic, around 65 to 70% come from the genetic origin. And we have witnessed a lot of genetic events in the past, and there will be other events also. So to address those threats and hazards, we need to be prepared, be ready to respond to this event also. This slide, I'll try to focus on what we have learned from COVID-19. One of the biggest things that we have learned is that health security or international health regulation or this preparedness is not only dependent on the health systems or IHR, it is beyond that. And we have noticed a lot of interdependencies that are dependent in order to respond, in order to be ready to respond those events. So I will not go in details all these interdependencies, but I would like to highlight out of these slides 4 or 5 things that we have learned as a key lessons from COVID-19. It doesn't mean that there are not, beyond 5 there are not other things also, but these are the 5 things I would like to highlight for today's session. First, on the workforces and training. So we, even in the advanced health system countries, many countries struggle to mobilize the source required in order to meet the demand of those health emergencies. And it is not only during the emergency, but that capacity or capabilities needs to be in place with the proper training, adequate identification of human resource needs and skill needs also. This is one thing which is key for the preparedness and readiness to respond the pandemic like COVID-19. Another thing which we also witnessed is the level of community engagement in order to communicate risk, in order to detect the cases, and those countries which have a better community engagement profiles, or a lot of community health workers, community volunteers happen to be responding pretty well compared to those countries which has limited capacities in community engagement. And as someone rightly said, that epidemics begins and ends at the community. From early detection to stamp out the event's potential threat at the community level is very essential in order to prevent epidemic and pandemic. The third thing which is important is a governance and a trust. It's a health governance, it's political governance, and the trust in the health, trust in the government, trust in healthcare services, as well as as trust in the public also. So this has even a lot of papers have been published looking at these elements, and it's very difficult to measure trust and other measures also, but these are the things which impacted in the COVID-19 pandemic. And for instance, public trusting government to follow the public health and social measures has we have witnessed several scenarios where public following the public health social measures and some reluctant communities which are not following, including anti-vax groups, which were having a movement in many places also. The fourth thing which I would like to highlight is funding, skill level funding and resources. It also links when I talk about the resources, then it links to the SARS also. But we also need a funding, and then the fundings are very limited also. And in order to efficiently use available funding, we need to know the prioritization also. What are our priorities? And this is where based on the risk, based on the vulnerabilities, we need to prioritize available funding also. As we move forward in the future, the funding will be limited as well because of a lot of recessions, a lot of impact of these kind of events. We need to learn about efficiencies and prioritization. Last but not the least, I will highlight the health system resiliency also. We cannot, as I always mention, that we cannot strengthen infection prevention control during emergencies. It should be part of health systems from primary healthcare to tertiary healthcare system, because it's a routine protocols or routine SOPs of every healthcare facilities, every healthcare workers. What we have also noticed that a lot of healthcare workers infected from the COVID-19 and other infectious disease also, because we don't have IPC, strengthened IPC capabilities in order to manage those emergencies also. In addition to that, we also need to continue some essential services. All those achievements that we have achieved so far were at risk due to COVID-19, because some of those essential health services we have to limit because of the priority to respond COVID-19, but those are essential. So these, and to strengthen and to ensure the continuity of those essential services, to ensure the workforce search capacity, IPCs, this is where we need to ensure that our health system is resilient. Now, this slide, I'll talk about another thing, which in terms of measurement, assessment, and what we have learned. So I have used two graphs. One is on the state parties annual reporting. Many of you are aware that all the member states, state parties report to WHA under Article 54 that all their implementation status of the IHR capacities. And this is the first blue, dark blue, and light blue graph shows that the changes in the preparedness capacity in terms of measuring for the IHR. So in 2018, global average was 61%. In 2021, it is 64%. But these capacity measures are more or less static. And this is where, based on the COVID-19 in the beginning, 2020, we develop an operational readiness index looking at those state parties annual report indicators, selected indicators, and publish that also, which is used in a COVID-19 strategic and preparedness response plan. And following that one, we realized when we use the outcome measures of COVID-19, like mortality, case fatality rate, and incidence rate, and when you start adjusting that operational readiness index, we noticed that those countries which were level 4 or 5 came down to level 2, 3, and some countries who are performing well, and they were in level 2 or 3 and moved to level 4. Then what we noticed that there is a dynamic variables which we need to include, and as well as those interdependencies. So this is where we develop this dynamic preparedness metric, which contains hazards of both ongoing epidemics and their probability and the epidemic burden also. And we also brought the vulnerability along with the capacity. So the next graph, when you see that the preparedness metric based on the hazards and vulnerability, it keeps on changing. So this is where we need to look at preparedness capacity based on the different risk hazards, not as a whole. So the capacity required for the diarrheal disease and capacity required for the hemorrhagic fever will be different. And during epidemic or pandemic like COVID-19, when the more resources are driven to response, and there are likely to happen on other events like diarrhea or measles outbreak. And if you look at the preparedness capacity in terms of those risks, it will go down. So this is where we need to consider risk-specific preparedness and readiness in each countries. What I'm trying to say from this slide is we have many countries were prepared. This is what all the existing assessment tools have shown. But what was missing is countries now prepared were not ready to respond to event like this. And what we have also witnessed, those countries who have experienced this kind of events in a small scale or medium scale, and these countries were quite well to responding to those events. And this is what we have learned also in the past. Based on this, and as you know that there were a lot of consultation, there are a lot of committees, reviews, and panels. And based on those independent reviews, we had synthesized around 300 plus recommendations. And WHO, as part of our Director General's vision, we developed these 10 proposals to build a safer world together, which we call Global Architecture for Health Emergency Preparedness, Response, and Resilience. So I'll briefly touch upon this one. And there was a member state consultation and presented during the World Health Assembly in 2022. It has 10 proposals covering 3 areas: governance, systems, and financing. And in the governance, there is a leadership where it recommends to have an emergency committee or council. The second one is looking at the regulations, some targeted amendments in the IHR. And the third thing is accountability. This is where universal health and preparedness review and other independent assessments are recommended. And my team is also responsible for developing UHPR metrics, which we are piloting right now. The second thing on the systems that we are looking at the capacity to be for the preparedness, readiness, and response to the threats and events with the early warning capacities, and then the coordination with the to develop the plans, mobilize the resource, and monitoring the activities. And one thing is that the health only cannot do everything. We need a multi-sectoral whole of society approach. And this is where the collaboration among the different stakeholders, different entities at the national, subnational, and international level is required. And last 3 is on the financing health coordination. It's not only we need to rely external funding, but we need to ensure domestic funding are available for preparedness and response. If you look at the proportion of health budget that goes to the preparedness is very minimal. And if you look at overall on the emergency response, around 80 to 85% emergency fund usually go to the emergency response. We need to increase investment in a preparedness in order to prevent this panic and forget cycle as well. And then another thing is this preparedness financing mechanism. And you might have already heard there's the financing intermediary fund has been established in a World Bank as a secretariat and WHO as a technical support agency. At the same time, when we are preparing, there are events and also our emergencies is ongoing, and this is where we need a response financing also, and in terms of contingency fund and others. The 10th one is strengthening WHO. The 10th proposal is strengthening WHO at the country and regional level as well. And there is an ongoing discussion on the pandemic accord, and another meeting is upcoming in December. In summary, as you know, that there's an increasing number and impact of health emergency globally. Not only on health, it's also impact on socioeconomy, and $12 trillion is one of the example. The lessons learned from COVID-19, so we need to look beyond static capacity and health system. So these are interdependencies which we need to identify and we need to work with them. Each country has dynamic hazards and vulnerabilities that directly affect preparedness, readiness, and response capabilities. Focus on multi-sectoral actions and prioritization actions by developing plans, action plans, and linked to the national health and our overall national sector plan. In order to prepare for readiness and response based on the most relevant risks to each country. Response is dependent in a risk-specific preparedness and readiness and sustainable funding also, and which we need to ensure not only from the external source, but as well as the domestic sources. And recovery period goal to build resilient health system that support health security or pandemic preparedness and response is vital. With that, I conclude my presentation, and I would like to thank my colleagues and highlight some references that I have used for the slide. Back to you, Dr. Yodi.
Thank you very much, Dr. Nirmal. It's always enlightening to hear your presentations, and you are also very efficient, less than 20 minutes. So thank you for that. So we have extra time later on for discussions. I'm sure there are plenty of questions that will be coming, but we will keep that for the Q&A. So please stand by while we go to our second presentation. But before I invite our second presenter, I would also like to remind our participants, if you have questions already, you can already start typing them in the Q&A so that we can start curating them. So feel free to start typing your questions into the Q&A features, okay? So now we go to our second panelist, our second speaker, Professor David Heymann. Professor Heymann, he's currently a professor of infectious disease epidemiology at the London School of Hygiene, Tropical Medicine, and also the head of the Center on Global Health Security at Chatham House, London. From 2012 to March 2017, he was also chairman of Public Health England. And for 22 years, Professor Heymann was based at the WHO in Geneva on secondment from CDC. During that time, he rose from Chief of Research of the Global Program on AIDS to Founding Director of the Program on Emerging and Other Communicable Diseases. He then was named Executive Director of the Communicable Diseases Cluster, a position from which he headed the global response to SARS. And then finally, he was named Assistant Director for Health Security and the Director General's representative for polio eradications. Before joining WHO, Professor Heymann was based for 13 years in sub-Saharan Africa on assignment from CDC, where he worked in Cameroon, Cote d'Ivoire, DRC, and Malawi. Professor Heymann, can you hear us clearly?
Yes, thank you very much, Yodi, for that kind introduction. And also thanks to Nirmal for a very excellent presentation, which I believe will in many ways put a framework around what I'd like to say. So I'm going to start to share my screen.
Yes, please.
And what I've been asked to speak about is what did we learn from COVID-19? But in order to do that, I think we need to also speak about other coronaviruses because we've learned many lessons from them as well. And as you'll see, I'll concentrate on the health system, whereas Nirmal concentrated on that important fact that every group within the government needs to work together for pandemics moving forward. So let me just start by talking about the four coronaviruses that we knew way before 2003 when the first SARS outbreak occurred. And we knew about those, and we knew that they caused a common cold. They peaked in early spring in the Northern Hemisphere, and the elderly were the ones who had the most severe infections. We also knew that they came from the animal kingdom into humans, and that they then became endemic in human populations. And I'd like to concentrate on this one human coronavirus, OC43, because it sets a framework for what we can believe about the emergence of coronaviruses in the future. This virus was thought to come from cattle, and a group in Belgium, at Leuven in Belgium, did a molecular clock analysis of this virus, OC43, and that molecular clock analysis was as follows. They took all known specimens of human coronavirus, and you can see those under A on the right, and they did a genetic sequence of them from the 1950s onward. They then calculated a rate of mutation, and they took that rate of mutation backwards on that line A, and they came to a point between 1850 and 1900 when this virus would have been the same as the bovine, the cattle virus, which they also rotated back from its molecular clock analysis. And so between 1850 and 1900, they thought that these two viruses would have been about the same. Well, in 1892, there was a pandemic called the Russian influenza. And this was a pandemic which was very severe. It caused 1 million deaths in the world at that point of time, but it had neurological symptoms. Many of those were not consistent with influenza. So these researchers made a hypothesis back in 2004 that this pandemic was actually the emergence of OC43, and that as time went on, it became endemic in human populations. So what we've seen is that since 2003, there have been 3 outbreaks of COVID coronaviruses. And in 2003, there was the coronavirus, SARS coronavirus 1, that was thought to come from animals, live animals in markets, raccoon dogs, and possibly others. And this is that outbreak, as you will remember, those of you who were aware of public health at that time. It was an outbreak which was limited in time. It was stopped because there was a global effort to really work together to make travel recommendations and make sure that people weren't spreading the infection around the world. And this disease did not become endemic. In fact, the last human infections were laboratory accidents in Singapore, Taiwan, and China. But after that study, there were many studies that went on in China. One showed that 80% of the animals from one animal market contained significant levels of antibody to SARS coronavirus 1. And at the same time, looking in humans, it was found that 13% of animal traders in one market had evidence of having had coronavirus infection through antibody, whereas 1 to 3% of persons in 3 control groups in the communities had antibody, which suggested that market traders were at greater risk of infection and that they in some way pass it on to a few people in the communities. And then we had, but there was no action after this, unfortunately. That research was done, there was no follow-up action, and we see that we have had other coronavirus outbreaks since then. Here's MERS coronavirus, and this occurs, as you know, from camels. Camels carry the virus in their nasal passages, and this virus has spread to many parts around the world in humans, and we also know that it's present in camels in many parts of the world as well. And this is an outbreak that occurred from this infection. It's a nosocomial outbreak when one person who had been in Saudi Arabia came into South Korea, infected people in 3 health facilities. And then there was an outbreak that continued in several different health facilities, and 33 people died in this outbreak. We now know that camels are infected with this virus on the African continent, as well as in the Middle East, and we know that other camels show evidence of infection. Unfortunately, there's not enough research going on to determine exactly how to stop transmission, and what we know today is that this infection is very important, as you'll see in the upper right, for health care associated transmission, where there's poor infection prevention and control. It can transmit within households, but it doesn't transmit very well in communities, and it's thought to come from bats into camels that carry this virus. This virus is endemic in camels in the Middle East and Africa, and there's an occasional human infection, but we need to be worried about what the potential of this is should it mutate in a way that could cause a pandemic. So we've learned from these outbreaks that working in One Health is very important, where animal and human health and the environment are working together and assess together so that they can provide evidence that can be applied to prevention. Had in China there been worry about those studies that were done after the SARS outbreak, they could have possibly prevented future epidemics or pandemics from occurring. At the same time, in the coronavirus 2, SARS coronavirus 2 pandemic, the current pandemic, there were many modelers early on in the 2020s who were saying that we just needed to wait, that 50 to 75% of the population, if they were infected, transmission would stop. Remember, this was before vaccines, and this is what the modelers were saying. But if you understand what herd immunity really is, you can understand that they were wrong in suggesting this. Herd immunity, as you know, is the antibody or protection in the population that can, in fact, decrease transmission to zero. And a good example of this is shown in this. At the top, where there's a reproductive number of 4, one susceptible person gets infected, infects 4 others. But when there are 3 persons in that population who are protected, as you can see in the bottom in blue, then the reproductive number decreases to 1, and only 1 person gets infected, and eventually you end up with too little transmission to sustain transmission, and the disease disappears from populations. This has happened with smallpox, it's happening with polio. So herd immunity is the indirect protection of susceptible individuals from infection when a significant proportion of the population is immune and protected against infection or reinfection. And we know that when you're infected with the SARS coronavirus 2, you aren't protected for life. You can be reinfected. At the same time, herd immunity is the point at which the proportion of a population that is susceptible falls below the level needed for transmission. This is an example of the thresholds of immunity required to stop transmission of measles and rubella on the right. And you can see that that's well over 90% in order to stop their transmission and eliminate the infection transmission. The modelers, however, chose to use influenza A as their model, and they were saying that the threshold, as you can see, should be between 70 and 80%. Some important factors to know, though, about herd immunity is, though, if natural infection provides protective immunity, herd immunity can stop transmission. This was not the case with SARS coronavirus 2. At the same time, lockdowns actually decreased the ability to create herd immunity. So even though the modelers were saying we could reach it, in fact, we couldn't because we were locking down and preventing natural infection. And the only sure way of making a lasting protection is a vaccine which prevents infection in the long term. So let's look at these models, 75%. In fact, they assumed that the infection and/or vaccination provided lasting protection against infection and reinfection. That was a wrong assumption. They assumed that transmission is similar to influenza. That was a wrong assumption, as you'll see. And some assumed that there is a significant asymptomatic infection and transmission from persons who do not develop symptoms. And they used various figures because we didn't clearly understand and still don't understand how much transmission comes from persons who are asymptomatic. But the Japanese had shown early on that this was not, in fact, a disease that was the same as influenza. You could, in fact, stop outbreaks and you could trace backwards and see the source of infection. And so in 2020, when the modelers were busy making their assumptions, the Japanese were showing that you could stop outbreaks. It wasn't like influenza by, first of all, determining where transmission was occurring, and then stopping that transmission by shutting down sectors such as the nightlife sector, as you see here. And when they shut that down, the areas in purple, transmission actually stopped. They opened it again, it began, so they shut it down again. So what about herd immunity from SARS coronavirus 2? Well, we know that the immune response after naturally occurring infection only protects against serious illness and death, but we don't know how long that occurs. We're giving boosters now as a precautionary measure because we don't understand how long the duration occurs. And protection is only transient when there's infection. And we know from other coronaviruses that after 6 months, there can be a reinfection. The vaccines provide an immune response that protects against serious illness, but only transiently. And so it's much better to speak about population immunity, as most epidemiologists would prefer to do, rather than herd immunity for this coronavirus. So this is the percentage of population that has an immune response Natural infection and vaccination both contribute to that immune response and measured by random serological surveys. In the UK, in fact, it's known, for example, that 88% of people have had a second dose of vaccine and that many, many more have had booster doses. At the same time, antibody studies looking at population immunity show that population immunity is above 90%, 95%. And what we see is that this is keeping the infection at bay. This is the daily number of infections that are reported. And what's more important is that this is the deaths reported. And you can see that vaccination coverage, in addition to natural immunity from infection, is keeping death rates very low, way under 200 per week. So what we've learned is that epidemiological modeling is an important planning tool, but the selection of the parameters must be cautious and based on any existing knowledge. If that doesn't occur, we have a false assumption of what we should be doing, and many times that assumption is wrong. Third, I'd like to just remind you about the SARS coronavirus outbreak in 2003. This outbreak began sometime in November of 2002. And what you can see here is that as health workers in light color began to become infected, they amplified transmission. And that transmission caused a major outbreak by amplification of transmission in their homes, to their families, and also in health facilities. One of those persons who was treating patients in China, which had not reported the infection, went into Hong Kong, stayed overnight in a hotel. He was very sick. And if you look at the hotel floor plan where he stayed, you can see some red dots in front of his room K, which is green, and also in front of the lifts. And that is where, about 2 weeks after it was understood that transmission had occurred in this hotel, they did some scrapings of the carpets and they found PCR fragments of SARS coronavirus 1. What you can see also is that somehow people in all these rooms that were blue became infected and they returned to their countries with infection and caused the global outbreak. In addition, in Singapore and in Hong Kong and in many other countries, it was health workers who became infected, and they unfortunately then infected others and drove the epidemic into communities. This is again the outbreak, but it was stopped, and the last human infections, remember, were laboratory accidents in Singapore, Taiwan, and China, again showing that people working in health laboratories are at greatest risk, as well as our nurses and people working in hospitals. And so we've learned from these outbreaks that infectious diseases cannot be stopped as borders, and as they emerge, they are often inadvertently amplified by transmission of health workers. So we've learned one final lesson from SARS coronavirus 2, and that is that this can be a very serious infection if the populations are not immune, and it causes severe numbers of death. And you can see in the black line the death, and that as population immunity has increased, that is, the number of people who have been infected or been vaccinated increased, deaths decrease to a very low level where they're remaining today. Now, as Nirmal said, this outbreak was a great stress on health facilities everywhere. And this shows you a tent in Italy where they were obliged to put their intensive care into tents because their hospitals had collapsed, their hospital system had collapsed and could no longer take in patients. So we learned that health systems are very fragile, even in highly industrialized countries. At the same time from this, we understand that underlying health conditions are a greater risk for severe outcomes of infection than are those people who are in good health. As you can see on the left, those who were hospitalized, there were many, many more hospitalized in the US who had underlying health conditions, intensive care unit in the middle, and red were death, compared to those who had no underlying health conditions. And at the same time, we saw in the United States and in most countries that there was an excess of deaths other than reported COVID-19, and that these excess deaths were above what was historically expected, meaning that people couldn't get health care during the pandemic, and many of them became casualties and died. And so the final lesson for a health facility is to be better prepared in the future. There's a requirement for 3 interlocking functions: healthy populations that better resist consequences of infection, resilient healthcare to accommodate routine needs and a surge in patients, and strong evidence-based public health. This is nothing new. Nirmal has emphasized this in his presentation as well, but we need to consider health security, not just strong public health, but other areas of work as well, including working in a One Health environment, making sure that our epidemiological modeling is correct, and understanding that infectious diseases cannot be stopped at borders and that they are often inadvertently amplified in transmission by health workers. So to summarize, to be better prepared or to prevent pandemics in the future, there is a requirement for 3 interlocking functions within the health system. Healthy populations. We need to do a better job of keeping people less obese. We need to make sure that people don't have hypertension, other infections, diabetes, other diseases that cause severe outcomes from infection. We need resilient healthcare to accommodate routine health needs and a surge of patients during a pandemic. And at the same time, we need strong evidence-based public health, working in a One Health framework with a goal of prevention and a safety net of capacities for response. So thank you very much, Yodi. I've been very pleased to speak with you today and pleased to have been invited.
Thank you very much, Professor Heymann, for highlighting the lessons, the final lessons here on the slides from COVID-19. And also thank you very much for keeping in time. So we have ample time now for discussions. So if I may, I would like to invite Professor Heymann and Dr. Nirmal to turn on the camera so that we can start the Q&A session. And to the audience, once again, please type in your Q&A in the Q&A feature so that we can see them and we can curate them. And we have one already. This is from Dr. Vega, our alumni in Liverpool. This is to address to Professor Heymann. Rather than relying on vaccination record to estimate population immunity, is it worth for countries to invest and conduct periodic random seroprevalence survey like the ONS, UK as a more accurate estimate of population immunity dynamics? Professor Heymann.
Thanks, Yodi, and thanks for that question. In fact, there are seroprevalence surveys that are being done in many parts of the world. They're quite costly, and but they are important to understand what's going on. And if you've seen, for example, any of the outcomes from the serosurveillance activities being done in Senegal, you'll see that throughout Senegal, there's antibody levels to SARS coronavirus 2 way above 90% in some parts of the country, which suggests that this virus has caused less severe infection in African populations. And this is biologically feasible, as you know, because the median age in sub-Saharan Africa is 18 years. And so it appears that in Africa, because the serosurveys have been done in many countries, there is a high antibody level already, despite the fact that there's been very little vaccination. And this is thought to be due to population immunity from natural infection that for some reason was not as serious in African populations as in other populations. Thank you, Yodi. Back to you.
Thank you very much. Okay, do we have other questions? If you like, you can also raise your hand and then we can also try unmute you, but otherwise you can try to start by typing in the Q&A features. We still have 15 minutes.
Yodi, maybe Nirmal
Yes.
would have some ideas about serosurveys having been done in the Asian.
Okay. Yes, please, Pak Nirmal.
I think that we had past experience looking serosurvey for measles and other things, and I do remember when I was working for the measles and BPD surveillance, it's quite useful as well. But as David mentioned, it's pretty expensive also, and then the change in the variants frequently and regularly, and how regularly we can conduct seroprevalence is a bit of challenge as part of the process. But if the resources are available, and the workforce is available and it is a priority, I think that can give additional information as well. That's a 2 cents from me on the seroprevalence.
Okay, thank you, Nirmal. Do we have other questions already from the audience? Not yet.
No, I might, Yodi, I might just say,
yes,
and I think Nirmal could add that as well. You know, in the world today, we're worried about sharing of data, and it's very important that we share our information. And we've seen how countries have been willing to share information, especially about variants in the current pandemic. But we've also seen when they share that variant information, there have been some reactions by other countries that have decreased travel and trade. And this goes against what's been recommended by WHO within the international health regulations. So I think it's very important that we take a look at these documents, the international health regulations. And as Nirmal said, there's also discussion about some type of a pandemic treaty moving forward. And there's a good opportunity to see whether or not the international health regulations are still a tool which can, in fact, bring the world together, or if there's some other means that needs to be done. So I think Nirmal may have some ideas on that, because I think he's closer to this discussion, to the discussions on treaties than I am. And maybe Nirmal, you could say a word about that?
Yes, but Nirmal, please enlighten us on the progress on the treaties. We've been waiting for it for quite a while now.
Yeah, I think for the treaty, it's a member states driven process, and the discussion is going on. I don't have the recent update, and I know that there is a meeting in December 5 to 7 INB meeting to discuss further on this also. But one thing also, as per the request of various member states, there is a targeted amendment, and working group is working on the amendments or change in the IHR also. So we are hoping that in coming World Health Assembly and subsequent one, we will have some recommendations that will put forward in an assembly as a resolution to go forward, both for the pandemic ACOD and IHR. So from my side in this ongoing process, and there is a lot of discussion going on and among the member states and experts. I think it will be too early to mention what are the things going into the pandemic ACOD as well as those amendments also. Thank you. Back to you, Yodi.
Yes, thank you, Nirmal. Okay, while awaiting also the other questions, many of our participants here are actually postgraduate students, and many of them are actually seeking topics for their master thesis. So I'm wondering if both of you can actually suggest or recommend what would be relevant or important questions which students at the postgraduate level could address as a thesis project, which would be in line with our discussions this afternoon. Professor Heymann, perhaps you can.
I think Nirmal was ready.
Nirmal is my, I know.
Thinking to talk about, and it's really a privilege for me to share the panel with Dr. David. You know, he is our guru of communicable disease. You know, we grew up reading that handbook. What other thing we learned is, and this is what my unit and our department is working on, is developing the framework for preparedness, health security preparedness, research development, and innovation. And this is more on the operational and implementation research. We are not looking at the things that is already in the R&D blueprint, more on the vaccine therapeutics diagnostics, but other those operational and implementation research. So the whole concept or whole idea actually came into our discussion is that when we look at different capacities of countries, there are some areas where which even countries are putting a lot of resources, and still those capabilities or capacities are not improved. And then when we look at those challenges, it's more the challenges that we found at the operational or implementation level. And one other thing is this, that we usually have this global framework or regional framework, and then we think that this framework or tools fit for all, but it is not necessary also. And this is where this concept, like how we engage with the community or how we do the community-based surveillance, it definitely depends on those communities' structure, behavior, political environment, and all sort of things. What we, if I generalize, that's what we call settings, and the things that we need to do in order to address or bring community to be engaged in communicating risk, bringing or for the surveillance and other things. It will be differ from one community to another. The communities in Nepal and the communities in Kenya or in England will be different, and we need to look at those operational and implementation research. It doesn't cost a lot also, but we need to conduct those kind of research, which is not in priority for many agencies, because for the research more on those profit-driven industries, vaccine therapeutics and diagnostics are there, a lot of investment, but there's not much investment on the operational and implementation research. So this is where we are developed. We have finalized and we are about to publish it. It's in the final clearance process. And Yodi was part of the technical working group, and we have brought a lot of experts from all the geographic regions with equal diversity in the working group. And we identified 5 pillars to look at those operational and implementation research. And I think these are those areas. Definitely there will be, it's like a library of research areas or questions that postgraduate and PhD students can definitely conduct. We're also discussing with the National University of Singapore to coordinate that also, as well as Leeds University, who is our collaborating partner for health system for health security. So we are looking. And in addition to that, I just want to highlight also is that when we're developing the framework, we also started a small grant scheme, and which we launched last year together with the EMRO region with the support of TDR. So when I look at it, to conduct small research grant, and the TDR are the best place, who knows the area, who knows the administration, and they quite happily supported us. And we quite enthusiastically, we received a lot of proposals from EMRO. We found around 50. We're planning to grant around 8 proposals, but then some proposals are really so good, so we landed up granting to 13 out of 50. And it covers almost 8 countries in different areas focusing on the operational and implementation research. So one of my suggestions to upcoming cadres and emerging young public health leaders to also look at this operational and implementation research. Why there are anti-vax group, why people are not following the public health and social measures. What I think these are the things, this information that research can bring, not by those all types of assessment tools. So to generate evidence for decision making in for health security, we need this kind of operational and implementation research. It would be good to hear from David also. This one, and I'll share, David, our draft framework with you for your input as well.
Thank you, Nirmal, for highlighting this the operational implementation research questions, and we're looking forward to launch of the framework very soon. Professor Heymann, your take on research questions for postgraduates on issues related to pandemic preparedness.
Thank you, Yodi. Just to add to what Nirmal said, I think, what it's all about is prevention. prevention of emergence at the animal-human interface. And that includes many different things. In Indonesia, for example, it includes H5N1 and other influenzas in poultry and in live animal markets, making sure that that's understood, that the risks of transmission to humans are minimized. What are the risk factors? And also the major area of antimicrobial resistance, which will be the next major emphasis, I believe, and Nirmal can correct me if I'm wrong, but of WHO, looking to see how antimicrobial resistance evolution can decrease both in the animal kingdom, in the human kingdom, and in the environment. And for that, I think there are lots of ideas coming from the quadripartite, which is a group of 4 international agencies: WHO, the World Health Organization for Animals, WHO, and the UN Environmental Program. So many ideas looking at how to prevent emergence, understanding what goes on in live animal markets. That's behavior, as Nirmal said, very important. Also, what are the pathogens that might be causing risk in poultry or in other live animals? And also, what are the different problems with antimicrobial resistance, and how are they linked to antibiotic use, both in animals and in humans? So just a few more ideas to add to those that Nirmal has already so well explained. Over, back to you.
Okay, thank you, Professor. Yes, please.
Yeah.
Yes.
I think you know, as I worked 5 years in Indonesia, and I always cite an example of Indonesia, that what we can learn from there, and it's One Health is amazing there. We started bringing like the rabies in Bali, and then the DHO and district veterinary officers sharing the information at the district level for even influenza. I think these are the key things that we can learn from Indonesia also, and we can go, or we can conduct additional research. What are those factors you identified that bring those sectors together? You know, Bali rabies is a classical, a great example. I do remember when I joined WHO in Indonesia in 2011, the first thing with what we witness is that UNICEF allocated some resources and provided to FAO to support to get the dog vaccines for vaccination in Bali, you know, and this is a classical example of multi-sectoral or whole of society approach, and WHO facilitating those movement of fund to one agency to others, and the FAO leading to the Ministry of Agriculture. I just would like to acknowledge that the contribution from Indonesia to One Health world. Back to you.
Thank you very much, Pak Nirmal, for highlighting that. Okay, we only have a few minutes left, and I don't see additional questions. So just one final question. As you know, at the moment, Indonesia is hosting the G20. So leaders from the G20 is actually now convening in Bali at the moment. And the technical teams now is very busy drafting the declaration, which will be announced very soon among G20 leaders. So if you have the chance to actually insert 1 or 2 sentences, which will be very important and to be part of that declaration of G20 leader for pandemic preparedness, what would that be? Who wants to go first?
Nirmal, do you want to go?
Sure. Thank you. I think that's I could have thought about that question, but immediately, you know, what it comes to my mind is investment on preparedness. You know, what we have noticed is, you know, with the people called panic neglect or panic forget cycle, we always remember preparedness during emergency or event, and then once event is over, then we forgot. And its investment is not only about investing in terms of financially, but also other resources, also human resources, other logistics as well. So if I had a chance to include, and that in any kind of declaration, is to increase at least domestic funding on preparedness, because we can't only rely on international or donor funding also. That that would be good to start as a seed money, but at the end, to have a sustainable financing, just to ensure sustainable resources, it's domestic. Clearly, we need to invest more on preparedness and readiness. So my take on will be like a more funding or resources in a regular budget of government in preparedness and response. I'm not saying only in health, because preparedness and readiness is, as David mentioned, it's beyond health. We need to bring all sectors together. So overall investment in a preparedness domestically and increasing some targets would be my take on it. Back to you.
Thank you, Nirmal. So investment in preparedness, especially domestically, and also increase some targets. Professor Heymann, what would be your suggestion for the declaration?
Yeah, I think Nirmal has hit it right on the nail right on the head. I would just add that if you link this preparedness to health security, political leaders seem to understand health security. And to do that, you might want to get into the declaration something that a health system can be prepared if populations are healthy. That means good health promotion. If there's a surge capacity that can deal with pandemic patients as well as routine health issues, and if there's strong public health that's working in a One Health manner, in fact, you can be prepared and you can actually, at some point, prevent infections and pandemics from occurring. So just to complement what Nirmal said, just to add a few more words, and that was what I would put into a declaration. Thanks very much, Yodi. Back to you.
Thank you, Professor Heymann, and that nicely closes as a closing also for these sessions. So thank you, Pak Nirmal. Thank you, Professor Heymann, for that final remarks of this investment and also for the healthy population, the preparedness, and so forth. And also thank you for the research questions for the postgraduate students. I'm looking forward to see some of these questions being addressed by the students through the theses, which hopefully will also then contribute to preparedness and readiness. So thank you again, Pak Nirmal, Professor Heymann. Thank you for your contribution. Thank you for your insights, and enjoy the rest of the week. Thank you.
Thank you. Terima kasih banyak.
Terima kasih, Pak Nirmal. Take care. Bye-bye.
Bye.